I trained at Mayo Clinic, not the University of Rochester, Minnesota.
I'm sorry. No problem. Sorry.
It doesn't make a big difference, except if I went there. Let's try this. So there are 4 points that I'd like to give you. And then Cecil Burley asked if I would give any extra time. He said, well, we give you another 10 minutes. And so on those, I have just a slide that has some points that will be kind of one-liners, rules of thumb. First point is how to identify a good or a bad biometer scan if you have either the IOL Master or the Lensstar. So this is a picture of an IOL Master 5. How many people have a 700, an IOL Master 700? And how many use a Lensstar? Okay, all right. Anybody use both? So you two guys, this is a talk that I would love to talk to you two afterward. Oh, yeah, Stan, that's no fair. Stan is my partner, so of course he does, because we do together. Anyway, this picture right there, the arrow shows the B scan that comes on every IOL Master printout. And we're going to look at that one quite a bit. That's how you'll be able to tell if it's a good scan or a bad scan. And there's a blow-up of that B scan. This is a patient who we scanned with both instruments, and we know that the IOL Master got it wrong. It spiked at 1.73 millimeters too short. And we know from the Lensstar it was 5.53. And how can you tell from that little mark right there? That tells you where the machine thinks the back of the lens is. It should be over here. So how much does that matter? I show this to my son, Matt Cooke, who's a, I'll say an IOL power calculation skeptic. Much to my chagrin, but oh well. Anyway, my wife would say he's a little more balanced. How much does the lens thickness matter? So he asked me, he said, okay, so the lens thickness isn't right, so how much does that matter? So before we did the one study, we did this study, and this took 926 eyes. These eyes had already been done. They're not being remeasured. These are eyes, a data set that I already had, and in this data set, there are a lot of short and long eyes, and in this, I just moved the lens, so the thickness, I moved the size of the lens thickness by 1.73 millimeters, and calculated with a bunch of different formulas and tried to figure out, okay, how much would the IOL change on the prediction based on decreasing the lens thickness by 1.73 millimeters. And so this is the IOL power, not the refraction. And it varies a lot depending on if you have a long eye or short eye or average eye. But if you look at the short eyes where it matters the most, and if you look at those 2 formulas that it seems to matter the most on, it's quite a bit. Now, those 4 formulas, the Hoffer Q, the old ones, you don't use the lens thickness in the calculation, so it doesn't affect them at all. But back to this, at 1.73 millimeters, you notice that's kind of the amount that's in the Olsen. So the rule of thumb there would be that there's a 1-to-1 relationship that the IOL power is off about a diopter for every diopter of lens thickness error. It's more for short eyes and it's less for long eyes. But just use that kind of in your head. I've got a lot of rule of thumb in this talk today. This is a study that Kamran Riaz and I did. Kamran's at Dean McGee. And we looked first at the lens thickness measurement. Now, the reason we chose the lens thickness is if you think about what the biometer is doing, when it hits the front of the lens, that's your ACD. And when it hits the back of the lens, that's your lens thickness. And so all the different parts of the eye, basically, other than the cornea and the retina, which is the IOL Master 500, any of the new machines, the new formulas, it's where the lens thickness is that makes a difference. And so we just looked at that and compared these and called it Tale of Two Cities because it turns out both of us had a machine that was broken and we didn't know it. And they had a broken Lensstar, and we had a broken IOL Master. And so in trying to figure out why our stuff was so different is how we picked up how to tell how these things are not working well if you have one. So the first thing we did is we looked at the IOL Master. This is all Oklahoma City data. IOL Master 700 versus Lensstar. The difference was greater than 0.1 millimeters in 70% of the cases. And if you look at greater than a half millimeter, now the rule of thumb would say that's for these 13,000 eyes, the IOL power, of course, if it's the Olsen, it's an average to short eye, the IOL power is going to be wrong by 1 unit, by half diopter in these eyes. So it's quite a bit of difference. How did we learn that the Lensstar was poor? So it had just actually been serviced that year, because when we figured it out, I know the Hochstreit guys pretty well. Tom Fisher, some of you might know, and Tom is our technician in our office, and Tom is a great guy. I see you smiling. Yeah, you can't think of Tom without smiling. So Tom used to work for Lensstar, for Hochstreit for several years, and so he said, oh, you got to call Ted, and Ted will make sure that machine's serviced properly. So contacted Ted and said, there's a problem with that Lensstar. And he said, well, it's interesting, and we just serviced it a year ago. And yet the data for the prior 3 years was all trashy. So before and after their servicing, it was poor. So how did we figure it out? Well, my son Tim, not Matt, the ophthalmology guy, but Tim loves computing, and he wrote a program that looks at the Lensstar data, and we're going to see that line right there. That's a floor, and with his program, it looks at the data and removes the floor so you can see what's happening underneath it. It's called Spike Finder. That's what, it's available for free if any of you want it. He's got it on GitHub. You can do it, load it up yourself. But any rate, the spikes here, this is a printout from a Lensstar machine, and those spikes in blue, you can see the little symbol there. That's where the machine was marked for the lens thickness. Now, this is a typical Lensstar profile. You see where the two arrows are? That's the anterior and the posterior capsule spike. So the geometry of the lens shows up in the A-scan. The first spike is the anterior capsule, the next spike is the cortex and the nucleus. Sometimes it's low like that, sometimes it's higher than the cortex spikes, and then you reverse it on the way out in the back. You don't see either the front or the back posterior capsule spike. So beware of both the lens thickness and the ACD in an eye like this. So I'm going to just show you, that's the spike finder picture on the top there. And this is the same patient. This is data. This is from our office. This is a patient. And you can see down at the bottom, where this is that same eye. Well, that one right here. It's that eye. We're going to look at it here. You can see where the machine put the spikes. And those spikes are where those, in the top drawing, where those little red dots are, those red X's. And then down below it, well, here, I'll just show you here. That's where the spike was put. And you can see where the spike should have been put. You can see the anterior and the posterior capsule spikes. Down in the picture below is the actual picture from the Lensstar machine with the new spike positions. And you can see how far away that is from the lens, and so you can see why the lens thickness would be off so much. So contacted Hochstreit. They came, and they contract out in Oklahoma, and they sent their contractor to repair it. And so we were really excited to look at the data then and compared it, and good grief, it's 45%. It's still different by 45%. And you can look all the way down, not only 45% disagree, well, I guess I'll do that in a minute, where we look all the way down. So I thought, man, I wonder if that's routine. So we tested it in our office. This is, and we had the same thing. So I thought, my goodness, maybe every machine is, maybe these two machines are just that different. So you look all the way down, by 2 to 3 millimeters, it's almost the same numbers all the way across. 4 to 5 millimeters, yet without us knowing it, each one of us had a different machine that was broken. So 2 cities, Oklahoma City had a poor Lensstar machine, a really good IOL Master, and in our office we had a poor IOL Master 700 and a really good Lensstar. So inaccurate measurement. This is a printout from the IOL Master 700, and there again is the B scan, and you can see that posterior mark where it didn't hit the mark. And there it is again. So Tom Fisher, again, shows up in this talk. There's an SNR, signal-to-noise ratio bar, that's on every one of your IOL Masters. It's at the beginning of every IOL Master 700 scan. That picture shows up with that SNR bar. And he said, I noticed if I slide this thing all the way to the right, we get lots of good scans, and if I don't, we have all these lousy scans. And what that does is it actually changes the polarization of the machine. So the machines, the biometers send, not only is the light beam narrow, it's not a laser beam, but it's a very narrow beam of light as far as the bandwidth, but it's also needs to be polarized to work well. So what we did on this is, I wanted to see how this was working, so we took 123 consecutive patients, and Tom scanned them twice. The first time was with the SNR bar just in the default position, and the next time was with it moved, slid all the way to the right. The eyes were also scanned with the Lensstar on the same day. So they got 3 scans for the next 123 consecutive patients, and then we compared the lens thicknesses. So this is the default, the first scan on the IOL Master with the SNR in the standard position, the default position. Now we did 123 eyes. Okay, hang on. This is 115 eyes. What I'm going to show you next is the result of the prior 1,000 eyes, and you'll see the percents are almost the same. So the purpose for this is just to say it's a representative sample. Now you can ignore the one on the right. We'll just look at the one on the left there. You see we're 47% greater than the Lensstar, different from the Lensstar. We're using the Lensstar as our gold standard. We don't really know it's correct, except when we did the spike finder, the spikes look really good, and so we assume it's correct. But what we do know is that they're different by 47%. Then he slid that thing all the way to the right, and that's the green one there. Look at how it drops down now. Now we have 123 eyes. Why? It couldn't capture some of those people with the polarization out of whack. And so on the second scan, all 123 eyes were, we got all 123 eyes. And if you look at the amount that it's off, it's only different by 6%. And when we talked with Zeiss folks over in Germany, their comment was typically it should be 5% of the time. The IOL Master 500 is different. The IOL Master 700 is different from the Lensstar. And so we got it down to 6%. We go, okay, we think both machines are now working. So from that point on, Tom just scanned it all the way to the right. I talked to the guys. This was actually a research machine that we had, our IOL Master 700. We thought it was a new machine. It had been to different places before it came to our place. And so it came from Germany, and it ended up in the U.S., and so it wasn't polar. I don't think it had been properly, anyway, they hadn't been polarized. It was not polarized at the point when we had it. And you can see now the difference of greater than 1 millimeter. Before it was running 4 to 5%, and now it's down to 0%. So they came and they calibrated our 700, and it turns out now, look at the numbers, we're 5%, like they said it should be, different from the Lensstar. Our large numbers are down to 0%. So we're going to come back to, in a minute, I want to make sure I got points. If we get time, I'll show you, I do have the end of the story for the Oklahoma Lensstar, although it's not quite the end of the story, as you'll see. Anyway, so I'm going to review here. The point is, how can you tell if you have a good scan or a bad scan if you have only one of those machines and you don't have both machines? If you have the IOL Master, check for that back mark. Make sure it's on the back of the lens. And by mark, it's the back arrow that I'm talking about. And the front arrow shows the front of the lens. Occasionally, it won't spike the front of the lens properly. But usually, it's all in the posterior side. And then on the Lensstar, if you've got a couple of spikes there, that's a good scan, use it, plan on it. If both those are good, don't do anything else. Now this one, I would be suspect of this one because you don't have an anterior capsular spike or a posterior capsular spike. So this was another study we did, which I cut out of this talk. And if you do have what you think is a wrong lens thickness, what should you do? And the best thing to do is just run whatever your formula you normally run. Just leave the lens thickness blank. Don't put in a wrong number. It takes you way off sometimes. But if you leave it blank, then you're going to be fine. The Barrett without the lens thickness does really quite well. The Olsen without the lens thickness is horrible, but it's not used much in the U.S. So this was a different topic now. This is, okay, so my patient had, Cecil contacted me on this one, and he said, I got this patient who swears they had LASIK before, but can't get any records, and I don't know whether they had myopic LASIK or hyperopic LASIK. So this is, all right, so how can you figure this one out? You can do it in your head. So this is they have an IOL Master 700, and so this is a patient who had LASIK. I got an arrow there, and in yellow, this is using the myopic LASIK scan. And you can see that this is the Barrett True K, says put in a 23 diopter. Now if you change it to the hyperopic scan, it says put in a 22 diopter. So which one should you use? Well, what about the left eye? This is the left eye, and it says for the myopic, put in a 23, and the hyperopic, put in a 22. So which are you supposed to use? Well, you can tell by looking at the difference between the average TK value and the average K value. They call it spherical equivalent. Why, I don't know, and they call it the T spherical equivalent. That's their average K and their K. So if you look in the other eye, it's easy to subtract these two. You can see it's a plus 0.1. You'd take TK minus K. So this was a Seth Pantinelli case, and this is one where he said, the patient swears they had it in 2010, but I can't see a flap anywhere. I'm not sure they even had LASIK, but these are the Ks, and this is the Pennicam. I think it's Pennicam. Anyway, it's a topography. But if you subtract the two, you get a minus 0.26, and you get on both eyes, it's a minus 0.26, TK minus K. And I'll do one more. This is from Kamen Riaz. He said, I got a patient with monovision LASIK in the past, no old records. He was able to finally get the old records, but at that point had no old records. And he said, I am not sure which eye had which. And so here's the IOL Master, and you can see the number right versus left. In your head, just kind of think which eye had which. Those are the axial length, ACD. That's the biometry number. And here's the Ks. The right eye is a little steeper, so maybe he had hyperopic. Left eye is a little flatter, maybe he had myopic. But can't say with certainty. Here's the Penticam. This is the right eye. And here's the left eye. So the right eye is a little bit steeper. The axial printout's up there on the top left. And so it's a little steeper on the right eye than the left. So this is a paper that Carmen and I and Yasha Vanderstein put out in JCRS, and it was in a couple months ago in the journal. And I'm going to skip this and just simplify it to this. Of 547 LASIK eyes, of which, let me look back, I think 65 of them were hyperopic LASIK. We did the TK minus K, and if the value was less than 0, 99.4% of those had myopic LASIK. So you just do TK minus K. If it's a negative number, it was myopic. If it was a positive number, if it's greater than 6.06, then it's 93.5% were hyperopic. And of the others, probably because so many people have myopic LASIK compared to hyperopic, but 2/3 of the others in between the 0 and the 0.06 were myopic LASIK. So you can have a pretty good idea, greater than 90% likelihood. So of those sample eyes I showed you, sure enough, the one that I was talking about that said it was a little steeper, that one was a positive. value, I've forgotten. I could go back and look at it. But at any rate, it was positive enough. It was hyperopic, and he found the records, and sure enough, it was hyperopic, and the others were all myopic. That TK minus K method was correct in all 6 of those eyes. I don't know, I love this stuff, so every now and then if people call or write a note or something, sometimes you need to know where's your local geek. So I'm the local geek for some people, and so I get involved in some of these. And every time I've ever tried it that we've been able to know, it's been correct. And you can do it in your head. You could do the same thing with the anterior posterior radius, but those don't have an on or an off. They're different, like the IOL Master. The IOL Master is 700, anterior to posterior to anterior ratio is different. I think it's 0.88, and the Pentacam is 0.83. Is that right? Thanks, Kyle. Those are your average values. And so is it more minus or more plus? And you don't have a cutoff. So the nice thing with this is we studied the cutoff. But you could do it. It's the same thing. It works the same way. So we've done 2 topics. I'm trying to help you remember we've done 4 topics. The first one, because I get brain fried when I come to a meeting like this, so I'm trying to just get it simple. First is how you know if your machine gave you a good lens thickness. And the second one is myopic versus hyperopic LASIK. Just in your head. TK minus K, if it's minus, they had myopic. This one, know with confidence if they had prior laser vision correction. This is a little different study. This is if you have a patient where you just have machine values and absolutely no history. The last one is if you have history they had myopic LASIK or hyperopic LASIK, how do you tell the difference? This is, you don't have any history. It could be keratoconus, could be a prior PKP, could be an RK. You haven't looked at the eye. This is machine blind, so to speak. So this is a paper. We looked at a lot more than that. That's maybe 60% of the things on the right side there. The different formulas we looked at, and the one that worked is that top left, right under the CRW index. We chose that for Cooke, Riaz, and Wendelstein. We didn't know what else to call it. So, anyway, the axial length over the K to the 4th minus axial length over K to the 4th, and we multiply it by 100. And then we modified it by the Ks and the corneal thickness. This modification ruled out, if you think about it, LASIK, you want to have a skinny cornea, right? A thin cornea because you're shaving it off if it's myopic LASIK. This is only picking up myopic LASIK. So if it's a myopic LASIK, it's a thin cornea. And so if it's thick, they probably had RK or they got some other problem. That's what that is. So it adds positive points, which is the wrong answer if it's a thick cornea. And then if it's keratoconus, you probably have a high K. And so we ruled out most of our keratoconic eyes by just giving points to the lower Ks, to flatter Ks. At any rate, if the total score was less than minus 0.22, there's a 93% chance that those eyes had prior myopic LASIK. That's a positive predictive value. Avoid confusion. Again, I try to make it clear, but I'm going to say it one more time. If you know they had LASIK, TK minus K. If you don't know they had LASIK, you just do that CRW. And hopefully Zeiss will put that on the machine, because who's going to remember something to the 4th and take the time to calculate it? Last of the 4 things I'd like to say is you can now run multiple new formulas at once. The ESCRS calculator is very similar to the ASCRS calculator, except the ESCRS calculator will run for normal formulas. The ASCRS is only for the myopic LASIK, for prior refractive surgery. So this is standard eyes, but you got a weird eye, and you just don't know what it is. And it runs 7 formulas there. Those are the 7 formulas that it runs. And it'll do them all at once by enter it once, and then it'll go out and auto-enter it into the websites for you, and then it'll bring back the data. And if any of often when you look at it, like last weekend or the one before, it only ran 4 formulas. If one of the authors changes their website a little, then it can't web scrape, and so it's always a little obnoxious. It's not really highly functional. Since we never change our formula, it always works. I mean, we don't change our website. We've changed our formula, but anyway. So now I'm going to get to the rules of thumb. These are going to be fast, one-liners. and then I'll get to the end of the story at Oklahoma. So I'm going to look at each one of these by themselves. That's if you want a snapshot of what they'll be, you can go ahead and take your pictures so you don't have to try to do them one at a time. So rule of thumb, you got a patient who had prior LASIK, you better not be putting in a 14 diopter IOL, and you better not be putting in a 30 diopter IOL. Why? Just think about what's happening. If you, wait a sec. Oh, yeah, okay, wait, why does this matter? Okay, so in our office, we use different online calculators for post-LASIK, and I hate the idea of going back and double-checking that my tech, Tom's pretty good, but okay, but my tech doesn't always enter the data in properly. And if they don't enter the data in, I am not excited about looking at every axial length and K1 and K2 to see if they entered it in properly. So I use these rule of thumbs every time I have a post-LASIK, and I'm just telling you so you can do the same rule of thumb and have a lot more confidence trusting what's on your machine. So it's the purpose for this is if you're using a web formula on a post-LASIK, it gives you a good idea, is this probably a reasonable value? And rule number one is it should be about 21.5 diopters. Why? Because the average lens used, at least in our practice, is a 21.5 diopter. And if you think about it, that means the lens power is about equivalent of the 21.5. Now, the lenses do get longer and shorter in different really short and long eyes. They have a pattern. You can kind of predict it. But the concept is it's about a 21.5 diopter lens. So if you've got a really long eye and you shave off the cornea so that it now is plano, what you've done is you've made the cornea difference adjust for that extra length, but you haven't changed the lens, so it's probably still going to be about a 21.5 diopter. And if you got a hyperopic eye and you add corneal power, you're probably going to end up with about a 21.5. So that's a rule of thumb number one. Rule of thumb number two, go up in power 2 or 3 spots for myopic LASIK. So what that means is if this, I took a picture of the Barrett. If the Barrett, now the Barrett, in this case, ran directly from the machine, so there's no data entry problem. So we're going to take the Barrett, whatever formula you usually use, you look at it and you say, okay, it calls for an 18, and if it's a myopic LASIK, you go up 2 or 3, so it should be about a 19 or 19.5. That's your rule of thumb. And if your machine is asking for a 24, yikes, look closely. That's the one you look at the Ks and the axial length. And if it's a hyperopic, you go the other way, 1 or 2 spots. So it's and you can remember that because hyperopic LASIK, they don't do 10 diopters of hyperopic LASIK. So they do less power, so it moves you off of your normal less in general. Another rule of thumb, Higas TK is blind to myopic LASIK and hyperopic LASIK. So if you don't have, you know they had LASIK and you cannot figure it out, and you do not have a, well, I'm going to drop. No, if you can't figure it out and you happen to have TK on your machine, you can use the Higas TK. I say data pending because that only makes sense to me, but I haven't proven it yet. We're starting a study where we'll figure that out. This one I've seen several times. The Higas L and the Shamus give about a half diopter of myopic prediction error. So if it calls for plano, you're going to, on average, get about a minus 0.4, minus 0.5. So to underpower that compared to the Higas L and the Shamus is a good rule of thumb. Another rule of thumb, you got Ks less than 39.2 on the average Ks. They had some kind of they got something really wrong with their cornea. Probably a refractive myopic surgery. And then this we found interesting. For keratoconic eyes, if the power of one of the meridians is greater than 50, they act a lot differently than if both meridians are less than 50. So if it's keratoconic and both are less than 50, both of the K1 and K2 are less than 50 diopters, a normal formula works better than the keratoconic formulas. I could show, we published that, but so That's all those same things except the last point I put back on this same slide in case you want to take the picture. First eye surprise. So you did your first eye and you end up with 1 diopter of unexpected hyperopia compared to what you started with. What do you do with the second eye? First of all, you try to wait at least 2 weeks. Ideally, most of the studies wait 4 weeks. But at least 2 weeks, at least a week, so you see, do I trust this? And that's different for RK eyes. I'll tell you about that in a sec. But you got hyperopic by 1 diopter, and you want to know, well, should I give 1 diopter? Should I give extra 1 diopter in the other eye? You give half the difference. So you give a half diopter extra. And there have been several studies that have shown they do it different ways, but they almost always end up with you figure out how much they were off on the first eye, you take half of that, and you shoot for, so you'd shoot for myopia of a 0.5 on the other eye. I should talk about keratoconic, not keratoconic, post-LASIK. If you're, well, skip that. Post-LASIK eye, well, I'll just give the example of a guy that I had that I'm doing his IOL exchange actually Tuesday. 7 weeks ago, I did he'd had post-RK and LASIK afterward. Wasn't sure if it was myopic or hyperopic, and I did one of these. And on first post-op day, he was 20/20 and amazed. I said, "We're in trouble, buddy. Sorry, you're not going to be happy 6 weeks from now." And sure enough, he's now -3. And so he can't stand it, and so we're doing the IOL exchange. The point is your post-LASIK takes 6 weeks to stabilize. We looked at his stabilized at 5 weeks. But don't do a re-op at 2 weeks on a I said LASIK, I think, on a post-RK. Okay, back to Oklahoma. So we have here, if you'll recall, they had a broken Lensstar that was actually tuned. Even though it was broken, it had been tuned the year before, and it was off 70% of the time. Then we complained, they fixed it, and it was off 45% of the time. We complained again, and they came back in the spring. I'm not sure when. That's where this, hang on. I guess I've added another thing. I'll come back to that if there's time. So now they're at 28%. They're better, but they're still not right on their Lensstar. And it's kind of frustrating I'm sure on their end. It's frustrating on my end. So we applied Spike Finder. That's what I was going to show you here. I guess I'll show you this. So we applied Spike Finder. David Murphy, their guy, went in and looked. I don't get to see these eyes. I get this patient one kind of stuff. But anyway, if you look at David Murphy is a research fellow over there who's working with Common Rios. If you look at the far right of that, where that dark line is, you go, maybe the lens is just a little beyond that. So maybe it's just slightly too short. So maybe the IOL Master maybe the Lensstar should be slightly longer. And right there is where the machine spiked it. This is the Lensstar machine at Dean McGee, and it's got, you see the front spikes are really tall. By the time it gets to the back of the lens, it can barely read the back of the lens. I don't know why, but it has to be polarized, I assume. Anyway, you can see that they put the spike, the machine did, it put it right there in the back of the cortex, and David moved it to the back of the lens with that spike. And I'll show you, that spike is very small, but you can see there's a distinct spike there where the capsule, posterior capsule is. So he moved it there, and it ended up, and I guess I don't have the values. Oh, there I did. I've got it up in the title. So this is patient 1. The original Lensstar spike was 0.41 diopters shorter than the IOL Master. And this is the one where I showed you where the IOL Master didn't maybe quite spike it properly. And you can see afterward it's now 0.13. So it went from 0.41 diopters shorter to 0.13 diopters longer. And they're actually at a bigger set of their data. This is just the most recent 100 eyes they had scanned. But prior to that, they're down to 20% on average. That was just a bad. At any rate, after Spike Finder, they went down to 3%. And so Spike Finder, just to replay what that does, all that does is it puts the spike where the Lensstar ideally should have put the spike because it gets rid of the floor so you can see where the spike should go.